So I have Dr. Olshansky from the University of Iowa joining us after a discussion on the role of PVC ablation in heart failure. So Dr. Olshansky,
Yes.
can you tell us, what are some of the mechanisms of benefits that we might see in PVC ablation for our patients with heart failure?
Well, PVCs can cause a variety of different problems. One of them is that you can get ventricular dyssynchrony. In other words, one ventricle contracting before the other. You can get AV dyssynchrony, which can also create hemodynamic problems. And you have the problem of a PVC causing what's known as post-extrasystolic potentiation. Whatever happens with the PVC, when you get the pause, you get extreme calcium release, and that actually seems to create a very inotropic state, but also can cause potential damage, at least ventricular dysfunction over time. So these are only some of the mechanisms. Tachycardia is another potential mechanism, and for any given individual, all of these things can participate. In addition, some patients have underlying structural disease to start with and then get a lot of PVCs, which make the problem even worse. And therefore, what you're really dealing with here is a vicious cycle. Part of this is a chicken and egg kind of a thing where the PVCs might cause heart failure, and heart failure then could also cause PVCs by the scar that's created. But on the other hand, PVCs can create heart failure that can create more PVCs and create this vicious cycle that just continues on and on to a bad consequence. And if you eliminate the PVCs in some of these patients, you can reverse the whole process.
Now, given the heterogeneity of these patients and their PVCs and the complexity of this chicken and egg situation, are there any predictors, any ways of best identifying our patients who will respond to PVC ablation?
Yes, there are. And I think there are a couple of things. So let me try to give a kind of a stepwise approach to the patient who has PVCs. For example, if you have a young patient who has developed palpitations and maybe has had an evaluation and has a normal heart function, but over time develops ventricular dysfunction. Someone who has a history that does not suggest ischemic heart disease, that does not suggest the development of a myocarditis or cardiomyopathy as the first initiating event, but has what appears to be an arrhythmia as the first cause, then that would be a patient that likely could benefit from a PVC ablation. The patient who has had a myocardial infarction and then, a year or two later develops more PVCs and then has ventricular dysfunction is less likely to benefit and more likely to have scar causing PVCs, at least in part. So the kind of patient who benefits and the kind of assessment that you do starts with what you think is the causative etiology for the cardiomyopathy. That can be hard to tell. If you have an older patient with multiple comorbidities, a patient who's got hypercholesterolemia, a patient who's got hypertension, you want to rule out the presence of ischemic heart disease. So you're going to evaluate the heart, look for a scar. You might do an ischemic workup depending on the patient. A lot of patients with PVCs, depending on the kind of PVCs, don't have ischemia as a primary cause, but it could be associated. PVCs associated with ischemia are often polymorphic, or at least have multiple morphologies. The kind of patient that's going to benefit from an ablation, for example, would be one in whom you can ablate the PVC because there's one morphology of PVC rather than having 4, 5, or 6. Those patients with multiple morphologies are more likely to have underlying structural disease. And those patients, depending on the situation, should first of all get some kind of quantitation of the amount of PVCs. Second of all, should get some kind of an evaluation besides necessarily an EKG and an echo. The reason for the EKG is to look for myocardial infarction, but also to look for the PVC morphology. And in addition, the quantitation is important to determine if you think you can get benefit. If you have more than 10,000 PVCs per 24 hours, there's a reasonable chance if you could eliminate those PVCs, you're going to improve ventricular function. But then you get these patients where you really don't know if the PVC is going to, when they go away, is the heart function going to improve or not? And in those cases, you might consider even an MRI scan to look for scar that may be the causative etiology. You don't tend to see scar in patients that have purely a PVC-induced cardiomyopathy. Again, some of these patients have a combination of things. They have scar, they have PVCs, the PVCs make the ventricular function worse. So then you have to consider what the ejection fraction is in lieu of the amount of scar. You might find a small scar, but a really lousy ejection fraction and a lot of PVCs, like bigeminy. In that case, you might consider an ablation. For the patient in whom there is a potential risk for ischemia, yes, they should get an evaluation for ischemia. And the problem here can become that the evaluation might even include cardiac catheterization, which I would favor in a patient with ventricular dysfunction when you don't know the etiology, to make sure that there isn't some causative problem related to the cardiomyopathy first before just going for a PVC ablation.